Are
We
you
are
live?
live now, doctor.
Okay. So thank you. Good evening, everyone. It's indeed a great pleasure to welcome you all to this wonderful webinar organized by the TNOA Young Ophthalmology Task Force. And as you all know, so this is our 70th year Platinum Jubilee year. So we have been celebrating this right from Tricon 23. And this has been our theme this year. Together we grow towards excellence. And Thursday has been designated for TNOA. So we have this pride of welcoming you to TNOA Thursday this August evening. So I welcome all the TNOA office bearers, leaders, our past president RK sir, our vice president Dr. Sujata Mohan, President-elect Dr. Arulmozhi Varman, Dr. Thangavelu, President Advisor, and all the MC members and leaders of senior ophthalmologists and young ophthalmologists to this webinar. So today's session is about unlocking innovations, webinar by the Young Ophthalmologist Task Force of TNOA. And let me take you to this month that was after that memorable Tricon 23 conference. So we are here with this platinum concept, and we had a wonderful webinar, wonderful feedback from all the members from the medical legal committee on empowering our members on 17th August 23 under the chairmanship of Dr. Ravindran and Dr. Murli Ariga. And we also had a meeting at Shankar Nethralaya by the TNOA Insurance Committee to discuss about the various insurance challenges. And thanks to Shankar Nethralaya and its leader, Dr. Girish, and team for hosting us. So we had a 2.5 hours marathon session on discussing challenges. And based on that, we also sent advisory to our members, the planning advisory, as well as a memorandum to all the insurance companies addressing our challenges and to work with us. So soon we'll be meeting them. We also organized a pilot training program with the help of MediAssist. Over 12 eye hospitals attended this. We'll be having this meeting in various places to train our staff, hospital administrators, and doctors on the various insurance related issues. Soon we will coming up with online and offline program. So what's coming up? We have the eye donation fortnight going on from August 25th to September 8th. So TNOA will be commemorating this with a fortnight webinar. Dr. Sharmila Devi and her team will be discussing these important topics, DARC, DSEC, and DMEC, with speakers Dr. S.K. Rao, Dr. Sujata Mohan, and Dr. Anand Pasadi. So please join us for this wonderful webinar next Thursday. We'll also be having an on-site meeting with the help of Kanchipuram District Ophthalmic Society, TNOA ARC meeting on 10th September 2023. I request members from Kanchipuram and surrounding district to attend this program and support it. And we have, so with the help of Quality and Infection Control Committee, we also organized, planning to organize a live wire infection control meeting. This will be held at Coimbatore, Hotel Radisson Blue, with the help of Coimbatore Society of Ophthalmic Surgeons and with support from CIPLA. So the flyer is ready and will soon reach you. I request members from Coimbatore and surrounding district to attend this session planned on the World Safety Day. So with the concept of safety initiative for infection control and prevention. So coming to today's program, Unveiling the Future and supporting our young ophthalmologists in publication and innovation. So we have this young team led by Dr. Nishant and Dr. Prasanna, who organized this webinar on innovations. And we all know innovation is the lens through which we can clearly envision a brighter future. And so we also have the support of the Madras Christian College MRF Center for Innovation. who is leading the innovation park with the MRF Center for Innovations. We have the principal of Madras Christian College with us. He'll be sharing his thoughts with us. And we also have the convener of MCC MRF Center, Dr. Aarti, with us, who will be sharing her thoughts on medical innovation and entrepreneurship, opportunities and challenges to encourage the young ophthalmologists among us to pathway of innovation. So this is the program. So we have 4 minutes each for presentation. We have 8 innovators presenting their innovation, and the panelists, we have seasoned innovators and academicians in the panel. Dr. Veni Priya, Dr. Devdutt, Dr. Suresh, Dr. Nivian, Dr. Manoj, and Dr. Aarti. And of course, ably supported by the office bearers of TNOA, the executive committee, and the MC. So this is the MCC MRF Innovation Park. They've been supporting the young innovators. So over 142 startups and 1 crore investment. So far, 28 startups. I'm sure working with them will help our own young innovators to scale up. I'm sure Sarthi will help us in this. So with these few words, I welcome all of you. We all know innovation is implementing new ideas that create value. So let's create value for our patients. Let's shape the future of ophthalmology, and let's continue to restore sight and hope. With this opening remarks, I welcome all of you to this webinar. Thank you so much for joining us this evening.
Thank you, sir. This is Dr. Nishant with the guidance of our president.
Thank you,
we are
Nishant.
going to kickstart our amazing session of young ophthalmology. So
can we invite some of our leaders to share a few words before we go on to the program?
Yes, definitely.
Dr. R.K. sir, followed by Dr. Sujata Mohan, Vice President.
Yes, sir.
Yeah, I don't want to waste much time because I'm also eagerly waiting to listen to the young ophthalmologist. And respected President, Dr. Nirmal, and Vice President, Dr. Sujata, Secretaries and ARC, Dr. Atik, and other young ophthalmologists of this session. Warm good evening to all of you. First of all, I have to thank and congratulate our the new young energetic President Nirmal for every week he is keeping us busy. It's very, very difficult to cope up with his speed. Really nice with different topics, insurance and safety, and infections and so on. No, that's very, very, but it's necessary for the present scenario to practice practice at this time of the zone. And really, I'm very happy. And today's session, the excellence in innovation, is definitely is because every day something is, even we think it's small thing, no, it's, which may be useful in our day-to-day practice. If you do it correctly and do it, can be replicated, and it can be much useful to the patient, as you mentioned, is definitely an innovation only. So in this way, our young ophthalmologists has done so much of work. I have to appreciate them, their level of thinking and their level of creativity. And really, it's because we are in the field for close to 40 years, but we didn't have that creativity. This one, but these people, definitely they are doing PG and just finished their post-graduation. They come up with so much of newer ideas. I'm definitely, I'm very, very happy and congratulate them. And I'm eagerly waiting to listen to their innovation. Thank you, Nirmal, and thank you,
sir.
All the best. Yeah.
Madam, you're muted. Dr. Sujata Mohan, Vice President of TNOA.
Good evening, everyone. It's indeed a great pleasure to participate in this program. I think not even August is not even over, and Dr. Nirmal has done so many activities in this 1 month itself. Like Dr. R.K. said, it's very exciting because each of them is very different and thought-provoking. And today's, I think we're all looking forward to see what are the innovations. So thinking out of the box, I think, is one of the greatest assets of youngsters. We didn't have YouTube, we didn't have social media, we didn't have so many things. So now they have everything on hand, and still they want to do something differently. And that is what we should appreciate and probably encourage them to do more. And this webinar is probably one of them to encourage, to bring out a new talent. All the very best to the speakers. And once again, thank you for the opportunity, Dr. Nirmal.
Thank you, madam. So I welcome the principal of MCC and chairman of the MRF Innovation Park, Dr. Paul Wilson. Is a dynamic principal, a lot of changes at MCC, and he was instrumental in bringing this MRF Park of Innovation to Tambaram. So Dr. Paul Wilson, thank you for joining us. So please share your wisdom as well as some guidance to these youngsters on the innovation and how MRF Park can guide us.
So good evening, doctors. Very happy to be part of this Tamil Nadu Ophthalmic Association program. I thank Dr. Nirmal and the organizers for having given me this opportunity. I would like to just take 10 minutes. Doctor, 10 minutes is fine? What is the time limit? Because you have given only 4 minutes to everyone.
Yes, sir. Maybe 5 minutes, sir.
5 minutes, fine. Thank you. So, thank you. Let me just give an introduction because Dr. Aarti here is the head of operations of MCC MRF Innovation Park is here, so she will be able to give you more information about Innovation Park. The idea why innovation, I think I saw one of the PPTs here on innovation. Innovation is not about core research, but it is about making use of the existing solutions for existing problems. We have to repurpose the existing research outcomes for the existing pain points in your own domain. And we are in the dispensation of knowledge economy. And when I took over as a principal, the first thought that came to me was, in what way I will try to rebrand the education, higher education. So with this question, I started contemplating, and I got this particular answer that mostly we have millennial kids, we call them as Gen Z kids. And they mostly identify themselves, mostly 60% of them all over the world, data says, that they identify themselves as innovators. That means they are not interested in any stereotypical jobs. They are job hoppers. And keeping that in mind, I wanted to move or navigate the higher education towards this particular aspect of creating value out of the knowledge that you have. So that we call it as innovation. So innovation is the one that has to create value. It's not about idea. Idea needs to be monetized. So by this, definitely, I can try to repurpose the higher education and make it more appealing to the younger generation. So with this idea, we wrote a proposal to MRF, and MRF is part of the chairman of MRF is an alumnus of Madras Christian College. And we had multiple sittings, and finally, they offered us around 30 crores as investment to create about 45,000 square feet of MCC MRF Innovation Park. We have multiple verticals as part of this innovation park. And one of them we plan to devote to healthcare. So that is the reason that we are here. So we now wanted to interact with the industry, and we would like to know the pain points authentically from the stakeholders and from the people in the world of work. So that is the reason that we are connected to the TNOA. The pain point from our side is that we are not in a position to connect to the industry. Because industry is not believing much on open innovations. They have their own implementation partners, and they want to make use of their closed innovations, and they want to confine themselves. And as a consequence, we are not able to democratize innovations. And we are now in the process of connecting to industries. One of the industries is healthcare industry that we are interested in. So now this innovation park will be launched in 2 months. And I invite the doctors to visit Madras Christian College. Whenever you plan to visit, let me know. I'll make arrangements for showing you the infrastructure that we have in Madras Christian College. From 2020 to 23, we have started functioning before we could complete the 45,000 square feet. We have started functioning in just 1,000 square feet, and we have got a good outcome from the students. The first aim that we are doing is now is creating a culture of innovation. So we are trying to redefine our education. We're trying to redefine the assessment patterns in Madras Christian College. Probably you might know there are two different assessment forms. One is formative assessment, other one is summative assessment. Formative assessment is for learning and summative assessment is off learning. So now we are redefining the formative assessment in such a way that any ideation can be monetized as marks. That means it's not about writing simply a conditioned questions and answers. Rather, if you are able to give new idea, if that new idea is adjudicated by the industry experts, then automatically they'll get their internal marks. So this is one of the innovations that we brought in assessments, and we have called that as an open forum. So among the three formative assessments, one of them is liberated as innovative assessment, where in the open forum, all the students who have got raw ideas, maybe polished ideas or raw ideas, they'll present to the industrialists. And when the industrialists are able to adjudicate, and finally they get the marks. And by this, we are trying to encourage more and more students as innovators, and it has really worked well. And we have formed Institution Innovation Council, which will lies in between the college and the innovation park. We are making efforts to register this body as a special purpose vehicle, because unless we register this as a Section 8 company, we will not be able to solicit funding from government agencies and other agencies. So this is a brief idea about the MCCMRF Innovation Park. I'm very happy that TNOA also is interested in talking about innovation. I'm sure this particular dispensation definitely looks forward for this. And for your information, India has been ranked in GII. It's called Global Innovation Index. It is 48 now. We were in 80th position. Exponentially, we quickly moved forward, and we moved to 48th position. I'm sure in the next year, 2024, we will quickly move on. This means that India is valuing innovation and India is investing on innovation. Keeping that in mind, if doctors are interested in being part of our mission, I welcome all the doctors to be part of our mission, and you can interact with our students. All these presentations can be, probably we can try to be an event partner. As an event partner, we can try to sponsor these events in our own institution, where you can try to talk to our own kids. And I'm sure this open innovation will democratize the aspect of innovation, and we'll be able to create value out of this. So I thank the doctor for having given me this opportunity. I wish you all the best. Thank you.
Thank you, sir. Thank you so much for your brief introduction and also welcoming us to the Innovation Park.
Yeah.
I'm sure it will be a unique experience for our youngsters to visit the park.
Welcome.
So we have Dr. Sriram, the Secretary of TNOA. Sriram,
I'm here, sir.
yeah. You have anything to announce or
Nothing
share
to
a few
announce.
words?
You made all the announcements. So I'm also eagerly looking forward to the session. I look at it more as an extension of one innovation session we had during the annual conference. And we also had given attractive prizes for the first two winners. So I don't want to keep people waiting. I'd like to move on with the session. Thank you, sir.
Yeah, thank you. So over to you, Nishant and Prasanna. So it's all yours.
Yes, thank you. Thank you so much, sir. So let's kickstart with our first innovator. So first we have Dr. Shirish Varghese, who is actually the Managing Director and Consultant Vitreoretinal Surgeon of Eye Microsurgery and Laser Center from Kerala. So he did his Masters in CMC Vellore, VR Fellowship from Arundai Hospital, Coimbatore. He's almost had 38 PubMed Index publications to his account and the best paper of the session of AIOS 2020. He's also a part of a lot of instruction courses presented in AIOS, TNA, KSUS, and whatnot conferences. So looking forward to hear what Dr. Shishir has to say.
Yeah, thank you. Thank you so much for the opportunity, TNOA. I'll just share my screen. Okay. Is this a screen visible?
Yes, sir, it's visible.
Yeah. So my topic is visualizing the obscure, that is chromophore-assisted retinal break detection. So it's a surgical posterior segment topic. And thank you once again for including me in this innovation session. So no financial interest in any of the products. So in this era of small gauge vitreoretinal surgeries with advanced technology as well as good illumination systems, 10% of cases of retinal detachment still require repeat pars plana vitrectomy because they tend to have recurrent retinal detachments. And they usually end up having a success of 51 to 81% in multiple different studies. So the main cause of these recurrence rates of detachments are mostly because of PVR, which is the highest incidence. And then you also tend to have missed retinal breaks, which contribute to around 64% causes of recurrent retinal detachments. So sometimes intraoperatively, it can be really difficult to localize these retinal breaks. When you do a repeat surgery for recurrent detachments, it can be extremely difficult because of the prior laser scars. So we devised, just rebranded a technique where using a 41 gauge cannula, we inject a dye into the subretinal space, and then we displace the dye, which then tends to come out through the unexisting or an occult break, which we could not really visualize intraoperatively. So going to the first patient, so this was a patient with a recurrent retinal detachment. There was no fundus view, vision was only PL, and we did not know what was the cause of the retinal detachment. We went in and did a pars plana lavage, tried to search for a break, but as you can see, we could not find where exactly the retinal break was. And so then using a subretinal injector, we injected BBG dye with a 41 gauge cannula, which was foot pedal controlled, and injected it into the subretinal space. So once you inject the dye into the subretinal space, and then you can displace it using a heavy liquid like perfluorocarbon liquid, and then the dye will come out through the break, which was previously which could not be visualized when you actually view it directly. So we're displacing it with PFCL, and then now we can see the dye which is coming out through the occult break. And so we can see it again in slow motion, the dye which is coming out through the break there, as you can see in the arrow. So this was one of the big advantages. And then we went on and did a routine surgery and finished it with putting silicone oil. So 3 months post-op, had good vision, 6/60, and at the retina was attached on OCT. So another case, again, a recurrent detachment, injected dye in the subretinal space. So make sure there are no bubbles in your injector, or you tend to have bubbles in the subretinal space. But nevertheless, we displace the dye. And then here again, you can see the dye which is coming out through some break, which was actually a laser scar which had given way. And then you can see, and then again, the surgery was done routinely and putting oil in the eye. So 3 months post-op, 6/36 vision, and retina was attached on OCT. So it may not work all the time. So this is one example where there was a PVR membrane, and then we just wanted to know whether there was really a break or not. And we injected the dye again in the subretinal space. But here, however, this time there was no localized break. And so we did a draining retinotomy and drained the fluid, and then we just lasered it. So this here, the cause of the break, cause of the recurrent detachment was the PVR rather than a missed or an occult break. So if you come to the review of literature, previously they have described the BBG is the least toxic dye available from among trypan blue and indocyanine green. And the longer the dye you put in the eye, the least toxic one is brilliant blue green. And previously, a similar technique has been described where they injected dye through the sclera, but then it can have complications like hypotony, choroidal retinal hemorrhage, retinal and vitreous incarceration, or even an iatrogenic break creation. And this previous studies have all been done, described with the trypan blue dye, which is known to be a little bit toxic to the RPE. So to conclude, subretinal dye injection is useful for occult or missed break, and you can detect it and you can manage the patient accordingly. So because it provides a color contrast, it helps in avoiding a posterior draining retinotomy, especially if the break is found. It's also helpful in recurrent detachments, and we use BBG in now multiple cases because it's the least toxic dye, and we report its use for this purpose in Indian eyes. Yeah, thank you.
Thank you, Shishir sir, for this wonderful innovative talk. We have an elite panel of Dr. Vini Priya ma'am, David Thomas sir, Suresh K sir, and a young panel with Nivian sir, Manu sir, and Aarti Hida. Anybody wants to add any comments?
Can you stop screen sharing, doctor?
Yeah.
We also see our own retinal surgeon, Dr. Sriram sir, also listening to it with great interest. Sir, do you want to add any quick comments on it, sir?
Let the panel come out first. Then I have a
Sure.
couple of
Yeah,
things. I'll add in
Shishir,
there.
this is Dr. Nivian here.
Yeah, hello, sir. Hello.
Sorry
Good
for my
evening.
video. Yeah. It was a good idea and excellent videos. So as you had already mentioned, this does not work if there is just a tractional component causing an RD.
Yes, it doesn't work. I mean, you can inject the dye, but then if there is no break, it's not going to come out. So then you know that you can make a draining retinotomy rather than directly just going and making a draining retinotomy when you have another occult break there. So that's the advantage of putting the dye in the subretinal space.
Yeah. So you have already highlighted these breaks next to the scar that is secondary leading to detachment, or also the small micro hole breaks that you see in the periphery that we tend to miss. I think it can be useful in those cases. But my question is, does this dye that goes subretinally, does it cause any discoloration or any toxicity to the retina later on?
Yeah, so that's what the BBG dye has been currently been studied in this decade and compared with the trypan blue and ICG. It's not found to be toxic to the RP. Even in a longer duration, the more toxic dye was trypan blue and even ICG. Even a minute of staining with ICG that was found to be the most toxic. So BBG among the three of them is the least toxic and no really harmful effects have been found of the dye.
Does it lead to any discoloration of the retina later on? Like
no, there is no discoloration because when you inject PFCL, you're actually displacing it away from the macula and the posterior pole.
Sriram, sir?
Thanks, Nivian. Nivian, two things. First, I'll answer Nivian's question. Nivian, BBG doesn't stain the retina. It only sits on the retina. So that is why when you inject PFCL, it gets displaced. Unlike trypan blue, which gets adherent to a basement membrane, BBG doesn't stick to any membrane. And under the retina, there are no membranes. You only have photoreceptors. And like what Dr. Varghese said, actually, I'd like to highlight a finer point in what he said. All dyes are toxic. BBG is probably the least toxic. All dyes are toxic. So let us not talk about a non-toxic dye. I don't think there's any non-toxic dye so far. One thing I wanted to point out is use of trypan blue has been around for almost more than 15 years, especially through a you have both transcleral and transretinal. One thing I wanted to tell you was you said you didn't find a break in the traction retinal detachment patient. Yes, you may not find a break, but see, the idea of injecting subretinal BBG and injecting heavy liquid is the dye gets displaced from posterior to anterior. That is most useful only in a regmatogenous RD with a peripheral break. If you're dealing with a case of PDR or some vascular retinopathy which you operated, when you expect a posterior break, ideally, if you inject the dye, if you do a fluid air exchange, which will displace a subretinal fluid from anterior to posterior, that is when you'll see exclusion of the dye. Not with PFCL. The moment you put your first bubble of PFCL, if there is a break, let us say near the disc, that will get blocked. Your dye will never come out. So that is with respect to your last case.
Yes, sir. That was actually a reg only, but complicated by
reg, yes, all are reg. But what I'm trying to say is it depends on where you expect the break. If you go back to your last third video, the detachment was predominantly posterior to equator. Anterior to equator was attached, which means you expect the break also to be posterior.
Posterior, yeah.
So you should start your tamponade from the ora to the disc, not from the disc to ora. Correct. That's what I'm. So only air will do that.
Dr. Shishir?
Am I correct, Nivian?
Yes.
I have a question.
Yes, agreed, Sriram. I was also about to ask subtotal RDs.
Dr. Shishir?
Yes, sir.
Once after you inject subretinally, that will it create a break and you do the endolaser for that position also?
No, that 40 gauge, 41 gauge cannula is extremely small. You really don't need to do a endolaser to that. It's a very small this thing, like a extremely small micro break.
Okay. Is there any follow-up you have done with electrophysiological studies in these patients?
No, that's one thing probably I need to do. Because I've
Dr.
done only
Shishir, I think you can probably do a electrophysiology study with the oil inside to see the toxicity actually, rather than depending on other studies. That will give you a very good
ERG in all the patients.
ERG would be a better, at least a mass response for it.
Yes, sir.
Thank you, Shishir sir, for generating such wide comments and wonderful discussion. We'll move on to the next speaker. Next speaker, we are going to have Dr. Prithvi Chandrakant. Yeah, is my screen visible? Yeah. So Prithvi needs no introduction, but He's one of the serial innovators. He's published more than 20 articles in PubMed Index journals. He is also the chief instructor in various instruction courses in regional and national conferences. So it's one of his top innovations is he started using trash from treasure. He started using the IOLs to really make ASPE, IOL scope, slim, smart, and Scooby-Doo. So over to you, Prithvi, for the next 4 minutes.
Can somebody allow me to share my screen? It's not.
You can share your screen now.
I'm having a small problem with the.
Okay. Is Saloni ready? Dr. Saloni, are you ready? Till Dr. Prithvi gets his presentation ready. Dr. Saloni?
Yes, sir.
Yeah. Are you ready to go?
Yes, okay.
Yeah, just a moment. Yes. So Dr. Saloni, as Prithvi is getting ready, we'll move to Dr. Saloni. So she's one of the final year residents who has just completed her residentship, but again, she's also one of the upcoming innovators with a lot of practical point of care innovations. So she's going to share us some insights on how the snapshots of learning is empowering the residents through social media. So over to you, Dr. Saloni.
Thank you, sir. First of all, thank you, TNOA, Dr. Prasanna sir and Dr. Nirmal sir for this opportunity to talk today. I will now share my screen. I would like to start my talk today by requesting everybody to rewind today by approximately 12 hours. That is today morning. What was the first thing you did after waking up? Probably checked your WhatsApp or Instagram or Facebook. That is how much social media has taken over our lives in the past decade. With this, I present to you snapshots of learning, empowering ophthalmology residency through social media. In the recent past, social media has revolutionized the ways of communication, sharing, and connecting with people. There are approximately 4.8 billion active social media users worldwide, and as we can all guess, the most popular platform is Facebook. Interestingly, India ranks second, preceded by China and succeeded by USA when it comes to social media usage. Regarding ophthalmology, social media can be leveraged into ophthalmology in various ways, like usage for residents and fellows, patient education, and professional use. Since ophthalmology is a highly visual-based field, it empowers, social media empowers residents with image-based and audiovisual learning tools and makes grasping uncomplicated. For patients, it is useful for creating awareness about eye pathologies and increasing their health literacy. And for professional use, to increase one's online presence for publicity, advertising, and sharing research work. So we thought, why not take this forward and incorporate social media into our residency program? Since all these platforms can be used in so many different arenas, we came up with an idea for each day of the week. All this is handled by first-year residents, which is a team of 14 people. A WhatsApp group has also been created for the same. So we start the day of the week with a quiz up Monday with a quiz question to rack our brains. We also put hashtags so that which makes the search very easier. If you just search hashtag quiz up Monday, all the quiz questions will come one after the other. This is especially useful for competitive exams or any quiz competitions or exams like OSCE, where a lot of image-based questions have been asked. Then comes up the Innovation Tuesday, wherein all the innovations, hacks to maximize patient care and smooth functioning of the hospital, right from OT, OPD, patient counseling, everything is covered under this post. This helps to inspire the young minds to contribute and think out of the box, and also to enhance their holistic development. Then comes the Awareness Wednesday, wherein all the research work which is done in the hospital is published under this post. This helps to the residents to know what all is happening in the hospital regarding research, and also gives them an idea of what to do with their own publications. Then we come to the middle of the week with a throwback to cherish old memories, major events, eminent personalities, and alumni that often visit. After all, social media is all about walking down the memory lane by sharing photos. Foresight Friday is basically to promote eco-friendly practices and to reduce the carbon footprint. We end the week with a surgical Saturday with tips and tricks for SICS, phaco, cornea surgeries, glaucoma surgeries, basically all the surgeries. On our channel, that is the AuroTube channel, we cover right from steps of SICS to how to handle complex cases like traumatic cataract, subluxated lens, etc. This is useful for first-year residents as well as practicing ophthalmologists. So recently we published this innovative way of learning in IJO. To summarize, basically we are trying to extrapolate the best out of these social media platforms to enhance learning in residency as well as develop a holistic approach for practicing ophthalmology. Thank you.
Thank you, Dr. Saloni. So we have with us Dr. Venipriya ma'am, who's actually very active in social media. Ma'am, few comments from you on Dr. Saloni's presentation. We have Dr. David Thomas sir also. Yeah.
I would like, hello, good evening, everyone. And thank you, TNOA, for this wonderful conference. And Dr. Saloni, it's an excellent presentation. I would like to also add a few things that even we could share our video-based skill transfer kind of a program also during this social media, so that all of us also be benefited. Yes. Along with the residency program, we could also add on the video assisted skills. Yes. It will also be very useful for all the specialties in ophthalmology. So you have expert doctors and specialists in your own place. So everyone can share tips of a lot of things. So it will be very useful for all of us. That will help everyone. That's an excellent presentation.
Good evening. Hello.
Yes, sir, you're audible, sir.
Yeah. I would like to make a comment. This is a nice initiative and excellent presentation. But the problem which I find with my postgraduates nowadays is, how do you validate? Am I audible?
Yes, sir, you're audible.
Yeah. How do you validate the information that is available in the social media? Your thing is, it's a closed group.
Yes, sir.
So the question of validation of knowledge doesn't occur. But once you go into the whole wild world of social media, it's a very thin line between knowledge and misinformation.
Yes, sir.
Okay, so many times when I ask my postgraduates where did they get to learn this, they say I learned it from this YouTube. I went to this channel. Okay, so my sincere request would be for postgraduates, book is the best thing, and our journals, these are the best way to validate our knowledge. These are accessories. If you can use this, like Thomas said, as a video assisted skill transfer, or if there is a two-way communication of like the Zoom meetings where we can do case presentation, that would be a better thing than social media being used as a primary source of knowledge. Whenever we are going approaching a social media where you are there is a query about whether the it is proper or it is not validated knowledge, it's better to validate that concept by cross-checking with a book or a journal.
Yeah, wonderful insight, Dr. Suresh. I think the security and privacy concern with social media does exist. So there are many medical legal challenges associated with this. So recently NMC came with a lot of guidelines and updates regarding this. Thankfully, it was put in the back burner. But learning this, as rightly said by Dr. Suresh, so this should not be the primary media. But for youngsters, yes, it is a exciting thing and easy to access. But ensure that we access the right information and right knowledge, and not if you see chatbot, they say at least 40% of this chat GPT medical knowledge is wrong. So this was a recent study. So any social media or recent innovation, we have to take it with a pinch of salt. So the right information from the textbooks and journals, and maybe accessory interesting things from the trivia from the social media. Using social media to learn is quite exciting, but ensure we get the right inputs. Thank you. That was a wonderful presentation. And so each day to remember and easy to recollect also. Well done.
Just a question, Doctor. Is there any age restrictions where there are some posts which cannot be posted in social media?
No, sir. This is all just, we have just assigned every like innovations or no age restriction is there, nothing like that.
Nishan, so can we move to the
So next we have Dr. Prithvi. So he's a medical officer and Department of Veterinary Service in Arundhai Hospital, Coimbatore, and he's got around 20 plus articles published with 100 plus scientific presentations. He's conducted various instruction courses in all the conferences, recipient award of APAO World ROP Congress, and much more. His very keen invention started when there were some lenses which were slipped and it fell. So these are the lenses which we have to discard. But using those IOL, he's made the slim, the smart, and the Scooby-Doo. Waiting to hear from you, Dr. Prithvi.
Thank you, sir. Thank you, TNOA. Thank you, TNOA YOFOS. Thank you, Nirmal, sir, for having me here, for giving me this opportunity. I'm sharing my presentation. I hope you can see it. Yeah, so I'll be talking about my innovation on slit scope. So as we know that the outreach program that we conduct is the key for preventing needless blindness, because we get to screen a lot of ocular pathologies, especially cataract. And then one big problem is we have just one instrument most of the time, because it's very difficult for us to take the slit lamp, or because it's very bulky and it could get damaged also. So we especially have just one instrument, that's a torchlight, to actually examine the whole eye. But I think it's time to change and we need something else. So the problem statement here was, what if we could make an instrument which would replicate the slit lamp, and hence be used in community outreach program where slit lamps are not available. So the solution was having a magnification, having slit illumination, and having imaging device. So these are the three components that we had to work on. And then we already had the solution for magnification and imaging device, that is the ASP, where a small chart paper is taken and a double-sided tape is inserted. A small hole is made using the paper puncher, and then an IOL of 15 or 20 diopter is put. Once this is done, we are converting the camera to a macro lens camera. With this, we can actually take images of eye in a very magnified manner. But the problem is, what about the slit illumination? That is what we worked on, and that is called the slit scope. These are my co-authors, and hence we opened up the slit lamp illumination part and learned the basic of its optics. Over here, we found that we had a illumination, a bulb with a in between which was a slit, which can be movable, and then we had a lens. So over here we used the IOL. So this IOL can be used like if we have a discarded IOL, we can use it, anything. And over here we use a 21 diopter IOL. So over here we made a slit using paper, and then we used a moon torchlight for the illumination. and we cut a small paper marker, and then we attach this IOL to it with a slit. And then we could over here with this 23, the first time we used was a 23 diopter IOL over here, and we could see how a slit was created. This way we made the slit scope, and this is the first video which we took. It was on my own eyes, and you can see how the slit was made and how thick it was. And this way the first slit scope was done using very minimal and very frugal stuffs. So then we thought, why not make it into a proper product? So we used the new technology of 3D printing, and then we started printing different kind of adapters. So one with a circle around with different diameters, one with a square, one with a slit, and the slit having different length and breadth. This way we could make a lot of adapters in very minimal cost, and that could be placed on top of the torchlight, and it costed just 350 rupees for me to make this. So once this was done, we had actually including the ASPE, we could start taking images. Here are a few video clips. As you can see, the first one is the immature cataract with PXF. You can see how beautifully it can be seen. Over here you can see a multifocal IOL. And these are all the images which we have taken only with the smartphone and ASPE and the slit scope. It does not have any slit lamp usage over here. You can see over here how corneal scar and PCIOL is seen. Over here you can see the blue dot cataract with sutural cataract. And it gives pretty good, and there is even a option of optical magnification, which can help us increase the magnification to see more clear. Over here you can see the brown cataract, you can see a mature cataract, and these are all images which can actually be compared to a slit lamp. And with the slit scope, we can actually start grading the cataract just at the outreach camp itself. So the slit scope is this very simple, cost-effective, do-it-yourself device. It can also be 3D printed, and it can actually start being used as an alternate to slit lamp. Thank you.
Thank you, Prithvi, for showing us how wealth can be made from waste, and that was a wonderful innovation. And I'm following you for the past 2-3 years with the slit scope, Scooby-Doo, and whatnot. So, what is your take on patenting innovations?
Yes, actually, it's a very important thing. Like if you think that it can be monetarily made into a product, you should actually go get a patent and then only present or publish anything. Yeah. So that's the first thing you should do. But I think this is a little open source, so I feel this is something which anybody can do. So it's a do-it-yourself method. So for now, I've not patented anything, but just for the greater good, let people use it, make it for themselves, and use it for their benefit. Yeah.
Okay. I have a question for Dr. Prithvi.
Yes.
Can I ask you a question? Yeah.
Yes.
Yeah. It was an excellent presentation. I would like to also know that for every diopter of the intraocular lens power, for example, there's a focal length.
Yes.
Where you do is in the thing is like if you use a magnifier for low vision devices, if there's a 2x magnifier, it is multiplied by 4, so it becomes 8 diopters. You convert it into 8 diopters and then divide the 100 by 8. So that is the focal length of that particular thing. So 100 by 8 is 12.5 or something like that. So if you are using a 20 diopter of intraocular lens on the back of the camera, you may have to hold it at 100 by 20, that is at 5 centimeters closer to the eye. So there is every magnifier has a kind of a specific focal length, so which we should maintain. So I think you're also having the same situation there also, isn't it? When you want to take it with the smartphone, how close do you go to the eye? It depends on the focal length of the particular lens that you use. So if you're using a 20 diopter, you may have to go as close as 100 by 20, that is 5 centimeters closer to the patient. If you're using an 8 diopter of intraocular lens, you may have to focus it at a 12.5 centimeter distance. So I think that principle you should also highlight on people who are trying to use that particular thing. Am I right? I want to clarify
Yes,
that.
sure, sir. Actually, you're absolutely right. First of all, there are two things. One, what we have said. The other thing is we are using the intraocular lens with 20 diopter, which is actually calculated for keeping it inside the eyes. So it is in relative to the aqueous humor that we have. So when it comes to the air, it actually increases. The dioptric power is actually increased when we are using it in the air. So if I'm telling it's 20, it's actually not 20 in relative to the air medium. It is actually more than that. And like you said, yeah, we have actually had a study in which we have used each and every lens. We have calculated how much centimeters it has to be held and how much field of view you can get also. So with that chart, we actually make these instruments, whatever we have done till now. So I've had, so with that respect, actually, we have made gonioscopy. So that gonioscopy requires the 8 diopter IOL, which we are using. So in the same way, 15 diopter is something which we can actually get the whole cornea into the picture. The whole cornea, you get it focused in one frame. If you want something like very magnified, we use a 20 or 25 diopters IOL. And again, we have also used 4 30 diopter lenses together to make a 120 diopter IOL collective, which can be used for imaging of the fungus and parasites also. And it is just using a smartphone. So we have been playing with IOLs here and there, everything, where whatever, even each one IOL, whichever you get, just take it, and we are starting using it to, do all these kind of experiments. And it is actually helping us a lot, especially the residents to whom we are giving these IOLs. They take a lot of images. One day itself, they take so many images. We send it across in WhatsApp. So each resident is able to take at least 5 to 10 images in a day and dissipate to everybody else. And it helps them learn so much.
Thank you, Dr. Prithvi. So if you don't mind, we'll just move on to the next with the shortage of time.
No.
So next we have Dr. Shivraj Thagre, who's a IVerter, whose innovation is non-contact eyelid version and NIST, needle incision subtenons anesthesia. So he did his DNB from Arvindai Hospital, Pondicherry, and he's currently a retina fellow in Arvindai Hospital, Pondicherry. Over to you, doctor.
Good evening, everyone. I would like to thank TNOA for giving me this opportunity to talk, and now I'll be sharing my screen. Okay. Is my screen visible?
Yes.
Yeah, okay. So I would like to present on 2 topics. One is IVerter and one is NIST, which is needle incision subtenous anesthesia. Me along with my teammates, Dr. Megha and Dr. Hirika. And I would also like to thank Dr. Venkatesh sir for continuously motivating us to come up with these innovations. So moving on to the reason why all these innovations came is this hackathon, which is an event which is organized in our hospital, which is like problem statement are presented and we all come together to solve those problems. So first innovation was something called needle incision subtenons anesthesia. Here the problem statement was whenever we administer subtenons anesthesia using Westcott's conjunctival scissors. Since we have to make a nick with the scissors, a lot of blood vessels, conjunctival vessels are damaged, which causes a lot of post procedure chemosis as well as some conjunctival hemorrhage. Then we thought, why not replace this scissors with a device which can just make a point entry. So we came up with this innovation of using lacrimal dilator, which is to be precisely Wilder bend lacrimal dilator size 3 to make a nick incision into the conjunctiva. As you can see in this video, the tenons and conjunctiva is grasped with the forceps, and this lacrimal dilator is just poked inside the conjunctiva to make a point entry. So as these then the anesthetic is injected, and as you can see, good block has been produced. So as the seizures has been avoided, a point entry is made, avoiding all the blood vessel zones. The incidence of subconjunctival hemorrhage following this process was found to be very less. Another thing is that the lacrimal, the cannula snugly fits into the hole. So the amount of anesthetic agent coming out of that hole is very less. So administered anesthetic agent is very less, which leads to less post-procedure IOP rise in this procedure. Next up is aorta. The problem statement was whenever the foreign body gets lodged into the upper tarsal conjunctiva, it becomes difficult to remove such a foreign body, especially when we have to do procedures like saline wash for any chemical injuries like acid or any cleansing agent and all those chemicals. Also, whenever the soot particles associated with the firecracker injury gets dislodged into the upper tarsal conjunctiva, so it becomes very difficult, especially when a person has to perform the saline wash. He has to hold the eyelid. He also has to perform the saline wash in absence of any assistant. So this device of us can help in this procedure. So as we all know, it becomes excessively difficult to evert the eyelids in patients with having loose skin, blepharoptosis, especially in patients without eyelashes where there is no horizontal traction force which can be generated, in uncooperative patients, in children, and in patients with gloved hand and antiseptic solution which is used in gloved hand. And other thing was like there is the general public cannot perform this procedure on their own. So we came up with the solution simply as using an ice cream stick and double-sided duct tape to create a device called iVerter. We also got it published in IGO. So as you can, I'll demonstrate these videos. So here's first video is showing up, like this is me and my teammates demonstrate on pediatric patient. And this is the other video in which we thought, why not a general nurse be able to carry out it out? And she was able to carry out it in the first attempt. Then we thought, why not the general public and like no paramedical or medical staff, any normal person, if they can use this procedure to see the universality of this product. And here we can see a mother everting the eyelid of a child, and this was the first time she did it. Like we didn't have to take the retakes 2 or 3 times. The first time that we just gave her the product and she was able to evert the eyelid. So we came up with this unskilled eyelid eversion, which can be done by general public also, like initially when they are coming from distant places. So at least primary first aid can be demonstrated by this patient before coming to ophthalmologist, and especially in patients without eyelashes and patients with lax skin and saline wash procedures. As this is a disposable device, it decreases the spread of infection. And as we have used wooden stick in this making this device, it's environmentally sustainable. We also presented this product in Government of India Puducherry Innovation Contest, and we were able to finish in the top 5 teams and were given a chance to be incubated in incubation center to produce a minimal viable product. Thank you.
Yeah, thank you, Shivraj. Can you stop sharing your screen? Yeah. Can we have comments from the panel? Any comments from the panel? Dr. David.
Innovation.
Yeah. Yes, ma'am.
What about the volume for subclinic? Is it going to change or anything?
Like we were able to use 1.5 ml, 1.5 to maximum 2 ml instead of using 2.5 to 3 ml of anesthetic agent. 1.5 ml was more than enough to produce the block.
It is not causing any chemosis, hemorrhage.
Ma'am, the incidence was less. Subconjunctival hemorrhage was definitely less. The chemosis was there, but the incidence of it was like, if we compare 10 patients, the number of patients with this technique was less as compared to the conventional technique.
Is it blunt or it is sharp, that punctal dilator? Usually
it's a blunt. It's a blunt instrument. Like there's yeah. So it won't cause any damage to the internal ocular tissues.
But it needs some force to infect the conjunctiva, no?
Yes, ma'am. Yes, ma'am. Yes, ma'am. A tangential force. So we don't have to direct it towards the ocular tissue. Since we grasp the tenons and subconjunctiva above, we have to give a tangential force to the globe instead of giving a perpendicular force.
The next one was awesome. That lead averter.
Thank you, ma'am. Thank you.
Shivraj, just one quick question. Excellent, simple, but very useful innovations. Just that eye inverter, how do you remove it after everting the lid because of the stickiness? Like,
yeah, Yes, sir. So basically, you just you tilt it over the like a vertical plane. Like you don't have to pull it or anything. You just gently go from one end to the other horizontally. It does not stick somehow. Even we don't know the exact physics behind it, but somehow it's not sticking to the lid. It just comes out.
Comes out, okay. Maybe depends on what duct tape you're using actually. That is
Yeah. Yes, sir.
sure. Excellent. Nice.
Dr. Shivraj, one quick comment. That excellent presentation regarding this diverter, thoroughly liked it. Regarding this subtenon, have you tried Venflon? Because somewhere I have come across an article where they have tried to give a subtenon with the Venflon, where the initial nick is done by the, of course, the sharp thing, and one you can just remove that, and the plastic thing can be pushed into the subtenon space. And they have tried it and they have published it. So have you tried it as a substitute? Because the the previous discussion, you are using a comparatively blunt instrument. The amount of force you are going to use is slightly more.
Yes.
So now with the Venflon, it will also be snugly fitting, and the amount of trauma will be less. So you can try that.
Yes, sir. So we thought about it actually, but since it's a sharp instrument, the vein flow, since most of our like the doctors who give block are generally residents, so we didn't want to make like it's little risky. That's what we felt, but we have not practically implemented it. Maybe we can do it, but what we felt is this punctum dilator is supposedly blunt instrument, so the risk of any ocular perforation will be comparatively less as compared to that of vein flow. That's why, keeping that in mind, we thought about it. But yeah, definitely we can give that a try.
One last question. Is it not better that we make sure that we are in the right plane of the subtenon incision by going right under the subtenon's tissues? Otherwise, sometimes we can end up going subconjunctivally and not subtenons. So we may have to make a little bit of a blunt dissection with the blunt cannula little and towards the posterior end, so that we make sure that the cannula goes right through the subtenon space and not through the subconjunctival space.
Correct, sir. Correct.
Because sometimes we will land a lot of chemosis instead of subtenons. We may give a subconjunctival thing accidentally, and we should make sure that we are in the subtenon's plane by making a small blunt dissection under the nick of the conjunctiva.
Correct, sir. That is absolutely correct. Like sometimes it happens to go into the subconjunctival space. So what we thought is the initial, when we the forceps which we hold the conjunctival tissue, just to make sure we apply a little more force to take up the subtenon's tissue as well. But as you said correctly, it happens sometimes that it goes into the subconjunctival space and it produces chemosis in the tissue. Yeah. Yes, sir.
Thank you, Dr. Shiva, and it was a wonderful presentation. So we are moving to the keynote speaker of the day. So we had 4 innovators up front, followed by the keynote now, and then again we'll have the other 4 innovators. So Dr. C. Aarti Ram, ma'am is the head of operations at MCC MRF Innovation Center, and she's having her own incubator for life sciences and healthcare. And she has developed programs with proven impact for nurturing innovation and managing IPR, especially intellectual property. Today, how do we need to protect it, or as we were discussing with Dr. Prithvi too. And Madam has mentored 500 plus early startups across India and designed and executed 8 customized programs for incubators. Over to you, Aarti ma'am, for a wonderful, short and succinct keynote. Can we have the next few minutes to you? And for want of time, can we have a very brief keynote, ma'am? Thank you.
Absolutely. It's a pleasure. Thank you so much, sir. And also, thank you for the opportunity right away. It has been, first I should be congratulating all the innovators, all the young doctors who have presented their innovations. And I should say that it was an overwhelming experience for me. It's been a long time since I, really interacted with doctors in this perspective, where they talk about innovations. It's so happy to know that, how much time you really dedicate in, coming up with novel ideas and also putting your hard work in doing that. So I just want to dedicate this time to definitely congratulate the young minds here. I'm not able to share my screen if you may allow, Prasanna. Yes. Thank you. Now I'm able to do.
Your screen is visible, ma'am. Yes, ma'am.
Yes. Okay. So my introduction has already been done. Just to quickly recap. My expertise lies in industrial biotechnology. I'm basically a doctorate in biotechnology, where I did my PhD on pharmacognosy and developing drugs. So that's where I ended up into research, and with that notion, I got the opportunity to set up incubators and life science incubators, and that's how my journey has been. MCC MRF Innovation Park is definitely different, with a lot more to medical entrepreneurship per se. So today, I'm going to just briefly give you the opportunities that lies. Of course, you all are aware of the various challenges, in medical entrepreneurship, starting from the lab structure to the approvals and how it is tough to get into the market. But I'm going to tell you about some of the opportunities that government is supporting, and also the various other private opportunities that lies, which we can go further. If you can see this particularly, eye care industry alone. Eye care industry alone is 1.6 billion. The size of the market is so much, and is growing at a rate of 28%. So that is what the global structures, global market tell us, and it is going to be, with so much of social media addictions and so much of, and also the lifestyle changes happening. Healthcare, especially eye care industry, is going to see a phenomenal drastic improvement, and also the requirement for innovations is tremendous. And that's where we require more and more doctors also turning into entrepreneurs. You all are already aware of the various, the market segments, especially in eye care. I've just pulled out a very interesting, a presentation from one of a leading investment company, where they mentioned about how the eye care industry alone has a market share, and what are the innovations that is required in different segments, and hence, which could really turn into entrepreneurship. And these are some interesting innovations that have made news in the current year, starting from having a bionic eye. Hope you are aware that so much of money and research is going on creating bionic eyes and superhumans, what we call as the superhumans. So starting from Google lenses to having implanted data, artificial intelligent eyes, and so much more. So bionic eye is a trend, and so much of R&D is being done for various capacities, for various even they say scuba divers are now going to have a special variety of goggles that can just capture, or with the camera attached for the underwater cameras, just with the click of eye. So many interesting innovations that I happened to read before this event especially. And of course the healthcare implants, more, now we are into the world where everything is getting printed, additive bioprinting, we are getting 3D printing, so that has become a norm of the day. So bioprinting is going to take over, and more organs, and more, especially corneal implants. I'm sure that you already must be using some of them. So more and more implants with more durability, more innovation in the spectrum is also expected, with of course a lot more interesting material researchers are happening in that spectrum. And surgery, when we talk about eye care, surgery is also one interesting segment which is looked after, and a lot of innovations is expected in that particular segment, where investments are also pouring in for simulations, surgeries, simulations for education, and surgeries for robotic surgeries, and also telemedicine opportunities where you can just connect over a virtual doctor. One interesting innovation that I found on topping the list is, of course, sustainable eyewear. And this particular eyewear that I'm showing here is not just about made up of wood. It says that the lens is also, corrective to myopia. So it automatically has an artificial intelligence which detects the altering vision impairments in the eye as the time goes, and also alters itself. So they are also researching so much on materials and coming up with novel self-reliant materials as well. So that's just a few gist of innovations that made me, really find it very interesting. So just, putting that among you. But to summarize all these innovations, these are the top few verticals which are looked for investments among the VC firms, and the global trends shows that there is a pool of fund being created for bioeconomy, and that especially for healthcare devices and telemedicines or targeted medicines. So all of this has a very unique opportunity, and more corporates, more VC firms, more governments, and more organizations are coming together to pool in funds for what is called as the bioeconomy. And care is definitely at the epicenter of all of this. What as doctors, or what as as part of the ecosystem we could contribute, we could do. It all begins with understanding what is the problem. So, of course, as doctors, you meet a lot of patients, you interact with so many people, and you are, every day your life is actually, solving problems. So, the problems that you actually encounter. But when you have to solve them, not everything is under your control, or, you may not be well-versed in all the topics. And that's where a creation of a proper consortium of colleges, research organizations, industries, and also the special government bodies are required. And that's where an incubator becomes an apex, bringing in all of this together for your idea to work. And when you have a brilliant idea at the laboratory, and you are able to, like you presented today, if you're able to present a POC, and that's where we should drive ourselves into scientific innovations. And these are just a glimpse of where India stands. And Dr. Wilson also mentioned in his presentations that India has moved tremendously in our index of patents and IPs. And we are far behind, but definitely we are making a very, very progressive jump towards having a lot of scientific innovations. They're being carefully documented and then commercialized, and then really marketed. So that is more important. And how do we do that? Of course, when we talk about medical entrepreneurship or bio-entrepreneurship, the most important component of it is the laboratory or the infrastructure for research. And that's where BioNest and BIRAC are government schemes that provide funds up to 1 crore to set up, to have your own, to get your facilities, and 50 lakhs is for any seed idea level, and more than 10 crore for setting up incubator facilities where you can promote more and more startups, innovations in this area. And of course, we have so many other venture funds like the ones mentioned, Sequoia being one of the prominent one, where they invest on healthcare ideas especially. We closely work with some of the hospitals also coming in and supporting startup innovations. in healthcare. And that's a good initiative. I would say that, I would even ask all these doctors who are associated with hospitals to come up with, funds raised from your hospital. A portion of your profit could be, pooled in and created a proper, healthcare fund where you can consistently promote ideas from these young entrepreneurs. I give it an idea to Dr. Nirmal to, that could be definitely possible with Startup Tamil Nadu. And Tamil Nadu government also, wanting to have 5 billion generated from 5 trillion generated economy from, startups as well. So all of this particular, graph again, I would want to highlight it because this exactly shows how the trend is moving towards improved and much better healthcare investments being, waiting to be exploited in the coming era. This chart actually, talks about the Q1 of this year. And you could understand that there are so many startups getting benefited every day, especially in eye care as well, on technology, as well as getting funding. So as I was mentioning about, the 3 important things that really, startups require. One is the infrastructure. The other is the, proper cross-disciplinary manpower and assistance and ecosystem. And thirdly is the funding. So keeping that in mind, we have created the MCC MRF Innovation Park, which has been, recognized as one of a promising incubator ranked among the top 5 in Tamil Nadu. And some of the facilities that you will be having inside that the Grant building, which is the largest among any arts and science college dedicated for innovation and entrepreneurship, spread across 50,000 square foot, will have a proper entrepreneurship cafe, which is a co-working space where you can have your facilities, have your office spaces and use it, and also a proper prototyping fab lab where small POCs could be created. Other than this, we have 7 research centers for excellences that are some of that which align with healthcare are computational sciences and analytics, and we have data analytics center for excellence. And we are more inclined toward health informatics, I should say. And that's where we also have a startup which promotes assistive devices for speech impaired people. So when I mentioned startups, some of you had mentioned that you had got an opportunity to get incubated in some really good incubators. So we especially specialize with our programs where we offer 3 important assistance in 3 important stages. One is the seed program, where we help idea to POC conversion. And next is the growth, where we help market a product with strategizing and accessing various funds and explore better markets. And then the scale, where we help them accelerate globally and explore expansion through setting up infrastructure, their own business units, and so on and so forth. So that is predominantly how we do it. And we do it with consistent interaction with technology partners, as well as with hospitals, with research centers. We interact with the government also and bring in the best of best for the startups to grow. And some of the other than the usual assistance provided to provided as services to startups, pilot study with 400 acres of campus and 7,000 students across 35 streams of branches. We ourselves have a proper, market for piloting, and we allow that on a controlled manner to completely test and validate the POCs. Yeah, so a glimpse of our startups. Our startups have raised approximately a cumulative sum of 6.5 crores till now. One particular Vivido Bots, a company that makes automatic painting bot for high-rise buildings, has raised recently a sum of 5 crores from an acceleration program called Brigade Leap. And our startup, who is, as I mentioned earlier, Alitris Technologies, who is developing an assistive device for the speech impaired people, differently abled people, to communicate normally, a health watch that can communicate hand gestures into voice, has been promoted heavily by the Tamil Nadu portals, and they have ordered a huge sum for all of their stations where they wanted to have it to communicate with the speech impaired and be able to write down their complaint, document their complaint. And also we have sustainable startups, startups that focus on sustainability, especially in different forms and functions. Yes, this is again a data on bioeconomy. With that, I wind off with given the time, and thank you for the opportunity again. And if you would like to, especially I was so impressed by the EduTech idea where promotion of education in a medical stream was very interesting, I must say. That is definitely doable. And I also agree to the point that social media learning is dangerous, especially when it comes to doctors. So, but the idea was brilliant. And also about a startup which mentioned about, I think, Mr. Dr. Praveen, or who mentioned about sustainable eyewear. So that was also interesting. So happy to connect, or happy to bring in more connections for you in this healthcare sector. I have one particularly, I just wanted to tell you, Dr. Nirmal Sir, Venture Center. Hope you're aware, the Venture Center at NICL, National Institute of in Pune, comes in legacy. NICL in Pune, they are an apex body for BIRAC and big grants, which focus on all kind of bio and medical grants. And a good partnership with them directly from the TNOA will be a brilliant move if you want to do that.
Yeah, thank you.
Thank you so much.
Dr. Aarti.
Yeah, thank you, ma'am. Thank you for this wonderful, enlightening talk on startups and IPR and whatnot, because that seems to be the order of the day. And you would like to ask you many questions, and then maybe we'll have the innovators presenting, and we'll have a good discussion at the end. So next, we'll move on to the fifth innovator. His innovation is called the SAM, Smart Arm for CAM, and his name is Dr. Hari Badri Anand, and he's also from Arvind Pondicherry. So over to you, Doctor, on your innovation called the SAM. How did you make it, and what was the idea behind it? Yeah, Dr. Hari, over to you.
Thank you, sir. Just give me 1 second. I'll get to sharing my screen right away.
Sure. So we'll have a quick, succinct presentation, Dr. Hari, in want of time.
Sure, sir.
4 minutes.
Yes, sir. I'll encompass all the points. So,
Sure.
very good evening to all. I'm extremely thankful to TNOA for providing me the opportunity to present on my work over here in this forum. So, what we have worked on is called SAM, short for Smart Arm for the CAM. So, ophthalmology, as we all know, is a field that relies on sight as much as it dedicates itself to saving sight. And as residents, we face an uphill task in our initial few months, wherein we have to pick up on a lot of findings, consult with the seniors, consult with the senior doctors, and then learn on what they are and how to recognize them in the future. And then what we felt as a need of the hour was proper digital records or proper photographic evidences, which we could refer to at a later point of time to recall and learn what we were supposed to learn as findings proper. So photo records are very important for documentation purposes, for purposes of patient education, for specialist referral purposes, for proper research and publication and corroborative publications, and for resident education, as I've mentioned at the earliest. So when we look at the existing solutions that are in the market for the same, we have these slit lamps which have inbuilt camera modules in them from top tier providers like Topcon and Adstraight. And then the issue with these kind of slit lamps is the amount of money that it costs for a single unit. So even in our tertiary care center, we have two, one in the cornea department and one in the glaucoma department. And if one of the students were to note a case of interest and wanted photographic documentation or evidence of the same, we have to take the patient to the said clinic, wait for the crowd to get over, and then go ahead with photography. When we look at the other available options, we have fundus on phone and other similar devices which employ a phone inbuilt to the device concerned. We have other devices which can be attached to a three-step slit lamp, and it acts as an intermediate and can allow your phone to plug in and record videos and photos from the same. We also have innovative approaches wherein lens adapters have been attached to smartphones and then they have been used for anterior segment photography. And so as we already heard from Dr. Prithvi, ASPI is also a very important tool which recognized and picked up on the potential of the smartphones and the computing power which we carry around in our pocket every single day. And what we usually see used in clinics is a commercially available lens adapter which is connected to a smartphone, and then we connect the same to an eyepiece of a slit lamp, which enables use of the same. So here we see my colleague setting up the conventionally available model, which, as you can see here in the short clip, is a time-consuming process. So it needs proper alignment. After proper alignment is achieved, the doctor can go ahead and take a photo with this. But then what happens is that after each use, the doctor has to dismantle the same, come back, and then reattach the same whenever a photographic record is needed. And another system that already exists in the market is Occupy, which works in a way that we also have indented in our problem statement. It plugs onto the eyepiece without causing any other issues and can hinge the phone outward or can rotate the phone outward without hampering visibility. But as you can see on a screengram from the landing page, every single option that is on sale is around $500, which is not affordable for many of the ophthalmologists or many of the students who are the intended population who they decide to serve. So looking at the prototypes that we had come up with, we were looking at a semi-permanent attachment to a slit lamp, which would enable us to attach a phone or any other video photographic recording device without compromising on the use of the slit lamp for patient examination. So we initially came up with a 3D printed model, and then we switched it over to using the lens adapter that was commercially available and attached it to the eyepiece. But then when we planned the hinge system for ourselves, the issue that we saw was that torsion was always occurring around the eyepiece and it always twisted off axis. So then we came up with the idea of the SAM, or the smart arm for the cam, wherein we envisioned a third separate arm for the slit lamp other than the optical arm and the illumination arm, which exists coaxially with the optical arm and can be mounted onto the slit lamp without causing much hindrance in it. So our maintenance department here at Arvind Pondicherry graciously offered to help us out with fashioning the same out of a sheet of stainless steel and welded together same for us. And then we used the discarded Topcon SL1E model to try this on, because 3D printing could not handle the weight of the phone at that point of time. The 3D printer that we had available could not print a product that was able to handle the weight of the smartphone's concern. So here we see a movement axis that we have set up for the proper alignment of the camera. We see X, Y, and Z axis which can be set up, and then we can align the eyepiece of the camera to the eyepiece of the lens. So here we see how the SAM is being set up. Here we have a staff from our instrument and maintenance department dismantling the SL1E slit lamp, mounting the SAM coaxially, mounting it back onto the pedestal, and then finally clipping back the illumination arm on. So this is what the finalized product looks like. And then looking at the initial setup, so if a doctor were to start his practice at the day, he has to plug the concerned phone in, and then he has to achieve alignment and then click a picture to ensure that it works properly. And as you can see, it takes under 30 seconds for the same. Now coming to the most important aspect, the repeat usage capabilities. So let's say that we are examining a patient right now. The apparatus slid into position. We take a quick image of the patient after focusing on the relevant part concerned. And then we can just swivel the phone outward, the apparatus outward for unhindered use. Also, this has much role to play in telemedicine and teleophthalmology opportunities, wherein trained personnel can use the same for video communication with doctors and share videos and pictures of the findings. The videos would be very helpful in situations wherein you are looking at a positive serial test or a positive force serial test, and where the patient needs urgent referral to a higher center. Now, the innovation can also accommodate other methods of recording, such as a GoPro or any other dedicated videographic or photographic recording device. And this is one of the first videos that we've shot on our SAM. So here you can see that we can use both the zoom capabilities and the optical capabilities of the smartphone as well as a slit lamp coupled together inside. Now, looking at the advantages that we strongly have, we have a semi-permanent method of imaging, offering stability with high quality imaging, depending on the phone that you use or depending on the recording device that you use. It's easy to assemble and dismantle and uses zoom capabilities of both the slit lamp and the phone and is very economical. So looking at the current challenges that we face an issue with adaptability to wider range of models, and then the design has to be tweaked to accommodate for the same. We also have issues, as I mentioned earlier, with the weight bearing capabilities. So we need to focus on maybe aluminum die casting of an arm or fashion for the same. Then we also have issues with the movement of the phone with respect to the attachment, for which we are working on a better system. So this is the team that was involved in production. I'd like to take this opportunity to thank every member of our team who put their hard work in, and also special mention to Dr. Venkatesh, our Chief Medical Officer at Aravind Pondicherry, because it was his brainchild, the hackathon, after which we had this problem statement and we had this brainchild of us. Thank you. Thank you for the patience.
Thank you, Doctor. We'll have a quick comment from the panel before we go to the next speaker. Dr. Manoj, sir, any quick comments?
That was a wonderful presentation from Hari. And the innovation is more economical and is the capabilities of using it simultaneously along with normal day-to-day practice. One of the fantastic innovations seen today from these presentations.
Thank you.
Thank you. Thank you, sir. We'll move on to the next speaker. Nishan, sir, kindly do the honors.
Yeah. So now we welcome Dr. Prabhu Krishna. So he is actually doing his DNB in Aravind Eye Hospital, Pondicherry. I think let's hear what he has got to say about Lumizo, achieving the cleanest block.
A very good evening to everyone. Thank you for this opportunity to TNOA, President Nirmal sir, and Dr. Nishant sir and Prasanna sir for this opportunity. I'd like to share my screen now. Am I audible, sir?
Yeah, perfectly audible.
Yeah. Yeah, so very good evening to everyone. I'd like to introduce our innovation, which is titled Lumizo. So basically, as we know, subtenance anesthesia is a very safe method of ocular anesthesia. It provides excellent anesthesia and akinesia for around 30 to 45 minutes. And it's a method that's fast gaining popularity. And this is a short video showing the same. As we see, a nick is made through the conjunctiva and tenons, and the anesthetic fluid is then injected into the subtenance space. As you can see, it's a very repetitive procedure, particularly in high volume centers. It takes place in a small working field and it requires very precise skills. And so this would, for you to do this, you would need a very ergonomic setting and you'll need good visualization of the working field, and you'll need a good illumination to properly see the tissues. So in our block room, we currently use a device which is a head-mounted torch type of device. It's very cumbersome to use. As you can see, it's very heavy and it only provides a good amount of illumination, but does not provide any magnification or ergonomic design. And more often than not, most people choose not to use it at all. And when a subtenance anesthesia doesn't go according to plan, these are the following complications that can occur. You can have excessive congestion, you can have severe chemosis, and you can have subconjunctival hemorrhage. And these can really hamper the surgeon's working field and affect the quality of surgery. And as for the doctor administering the blocks, it can give them a headache, it can give them neck pains and back pains if they're not in a proper posture or not in a good ergonomic setting. So we wanted to create a device which can provide, which has a good spectacle type ergonomic design, and it can give good magnification and also ample illumination. And hence we introduced to you LumiZoom. It's a spectacle type of device with illumination in the front and lenses for magnification. Yeah, and as you can see in this video, the doctor, it can be worn even by people wearing spectacles, and the light source is it can be tilted as per the user's convenience. So we have a pair of plus 1.5 diopter lenses for magnification at a working distance of around 40 to 50 centimeters. And it also provides ample illumination. So the device is powered by 2 lithium batteries, which provide a battery life of around 10 hours. And it comes with a wireless magnetic charging setup. So it has a high luminance and a low luminance mode. And we found that the low luminance mode was more than enough for our day-to-day work. And we get around 10 hours of battery life. So we don't need to charge it anytime during the day. So we conducted a short survey with eight of our ophthalmologists, and we found that all of them were quite happy with the magnification, and all of them were quite happy with the level of illumination it provided. But 3 out of 8 ophthalmologists said that the fitting was a bit loose. So we rectified that by adding a band in the rear of the device. So this resolved that issue. And all 8 said that they would recommend it to a friend. So we also found that it can have other applications such as helping in low vision aids, microelectrical work, dentistry, and surgery in low resource settings. So these are the other members of my team that I would like to thank. And I would like to thank our CMO, Dr. Venkatesh sir, for inspiring us and promoting this sort of innovative culture. Thank you.
Thank you, Dr. Prabhu. Personally, I think we used to have the binocular loop before, and now I think with the illumination that you are bringing in, I think it adds another more extra step to the armamentarium of block, and I think this is going to be upgrading to more into surgical fields as well. Many congrats on it.
Yes, sir. Thank you, sir.
Any quick comments from the panel before we move on to the next speaker? Satyan sir, do you want to make any comments? Manoj sir?
I have a quick comment to make. Actually, a similar device is available, which is a mounted device, which is a lens with the LED which is surrounding the lens. But the working distance is a little low. And as he said, the mobility, like since it is a spectacle form, it can be used anywhere. Whereas the commercially available one, it has to be kept in one place and where the blocking is taking place. Otherwise, it's a very nice innovation.
Thank you, sir. That device that you mentioned, sir, we actually used that to help load the IOLs during the surgery.
Correct.
Yeah, it also serves the similar purpose.
Yes, sir.
It was done by Dr. Bharat Gurnani and team, right? I think 2 years back during COVID time.
Yes, sir. Yes, sir.
Thank you, doctor.
Thank you, sir.
The next talk, smartphone mammography. So this is Dr. Pranesh Ravi, promising and upcoming ophthalmologist from our Your Society, and he's also the current head at the Eye Foundation Pollachi branch, and he's going to talk on the smart mammography. Over to you, Pranesh.
Thank you for the introduction. On the offset, I would like to thank TNOA, the office bearers, and Nirmal sir for the opportunity. Are my slides visible?
Yes, you are audible and it's visible.
Thank you very much. Just one second. We've started the
Yeah,
presentation.
you need to start the presentation.
Yes, just one second. Just one second.
Yeah, take your time. You just need to click slide share.
I'm having a small hiccup. Just 1 second. Is it visible now?
Yeah, perfect.
Okay, I'd like to share my take on smartphone meibography. So these are some of the conventional methods of meibography that are being used. All these devices have infrared camera associated with them. With that, you can understand and have a look at the morphology of the meibomian glands. And autoref is poor man's meibographer, as we all know it. So my ideation was to make a meibographic visualization in when I'm sitting on the slit lamp. So I had the idea of using a infrared filter as the as a device and using my camera as a capturing device. Camera can capture full spectrum of the light. So I thought I'll just block all the light except for the infrared and start taking pictures. So I bought an adjustable IR filter. I used this filter initially and I had a lot of problems because I was in a sit lamp setting and I had to take photographs. So overexposure, defocus, and poor output on grayscale conversion were my major issues. So I had to do a lot of workup with the device. I need to change the settings in the camera. I need to set up the lighting and all those stuff. Finally, for my phone, which I'm using, I stuck up with the settings which are being shown right now, so that I could get the right output required for the meibography, which I'm doing in a slit lamp. So this is the real-time imagery of the meibography, which I usually see, and this is you can actually see the morphology of the meibomian glands, and this is something which surprised me because I thought I had to take a photograph to document, but then I found out that I can use it in real time to appreciate how the meibomian glands are, to look at the dropout and tortuosity, and assess the damage and think about rectifiable measures like hot fomentation and massage or lippy flow of the patient is supportable. So my primary goal was sorted, and I needed to convert it to grayscale. So I stuck with a proprietary Google software called Snapseed, where I had used a setting called structure, which will enhance the differentiating contrast between the meibomian glands and the empty tarsus, so that I could document these while sitting at the slit lamp. So this is the final output images of the my meibographer and infrared camera, and I was able to comparably document the meibomian gland loss and tortuosity in a patient having a meibomian gland disease. Thank you for the opportunity.
Thank you, Pranesh, for bringing an economical innovation into play with the help of a smartphone.
Thank you.
Any quick comment on the panel? I think Nishan sir, you can also add on to certain points along with the panel.
Yeah, wonderful innovation, Pranesh.
Thank you, Mr. Thank you.
This is really a good thing because we are spending so much on the equipment for doing meibography, and this will be a real handy one because you need not go for such expensive thing, and it actually brings out an affordable solution.
Thank you.
And
Thank
when
you.
we picture, it's easy to tell our patients also that these are the gaps, these are the drop areas, these are the non-functional glands. So it will be a really useful thing for counseling the patients also. Wonderful. Well done.
Thank you. Thank you, sir. Thank you. Thank you.
So we'll move on to the last speaker of the day, who has been waiting patiently for the few minutes. So Dr. Jebin Bryan, sir, he needs no introduction, but he is one of the high volume cataract surgeons who has done more than 25,000 cataract surgeries, and he's a trainer, teacher, and he's also a surgical tutelage. He's involved in a lot of it. and he's going to talk on phaco sit, not phaco in a supine position, but in a sitting position. So, Jibin sir, over to you for the next few minutes.
Thank you. Thank you, TNOA, for giving me this opportunity. I'll share my video now.
Presentation is sitting position only, no?
Yes, sir.
Since it's
The
Zoom,
video, you're able to see my video?
yes, sir. You need to maximize your screen, sir, full screen.
Yes. No financial interest, no conflict of interest. Have you ever imagined your life restricted to the confines of a wheelchair and all that you can see is this? Oh wait, are you wondering if there is any technical snag? Well, no. This is precisely what our patient was seeing. A world of darkness. We are here to recount to you the tale of a frail 80-year-old lady who is wheelchair bound, afflicted with CVA, with right-sided hemiplegia, coronary artery disease, hypertension, diabetic mellitus, and spine deformity. All that she could do was either to be wheeled around in a wheelchair or just lay down on her sides. Every other task was either too excruciating or exhausting. She presented to us with bilateral mature cataract with both eye visual acuity of light perception. Her physical status score as per American Society of Anesthesiology was grade 4. Hence, due to the anesthetic threat, she was deferred surgery at several places before she approached us. We were in a dilemma whether to take her up for surgery or not. And that's when we came across the slogan of World Sight Day.
This World Sight Day, our theme is Love Your Eyes. This year, everyone counts.
That's when we thought, doesn't her quality of life count as well? A search of literature to tackle her physical status and to alienate her blindness due to bilateral mature cataract prompted us options such as phaco using slit lamp, phaco in a semi-reclined state, and phaco in motorized wheelchair. But here is the catch. We operate out in a secondary eye care facility in a small rural town in Tamil Nadu, where the access to sophisticated recliners and other resources are out of question. After extensive deliberation and counseling, we decided to attempt a sitting phacoemulsification surgical approach under anesthetic standby. The phaco sit, the novel, innovative 90-degree sitting phacoemulsification on a wheelchair. Here we describe the technique of phaco sit in a step-by-step manner. After a sterile surgical drape was plastered on one side of the OT wall, our patient was made to be seated upright in a wheelchair and her arms and head were comfortably rested over cushion. After skin preparation with 10% providin iodine and 5% topical drop in the eye, a sterile surgical drape covered her other eye, face and trunk and was held in place by sticking the upper and outer edges of the drape to the wall. A drain punch was fixed inferiorly. The adjustable operating microscope was set at an angle of approximately 70 to 80 degrees from the vertical plane. An inferior temporal self-sealing 2.8 mm clear corneal incision was made at 4 o'clock and 1 mm side port was made at 7 o'clock. After staining the anterior capsule with trypine blue, capsulorhexis was performed using a cystitome needle under high molecular weight OVD. Multiple bout of hydrodissection was done, followed by nucleus nutration. The direct chop technique was done with a 2 mm vertical chopper. The nucleus is divided into multiple fragments. 6 to 7 nuclear fragments are made and then emulsified one by one, taking care not to damage the corneal endothelium and posterior capsule. After phacoemulsification, cortex watch is being done. After forming the anterior chamber with OVD, a single piece foldable intraocular lens is being injected into the anterior chamber and placed inside the bag. After placing the IOL, a thorough visco wash is being done in the anterior chamber and behind the IOL. The corneal incision is hydrated, the anterior chamber is well formed. Throughout the course of surgery, her vitals were monitored by sphygmomanometer connected to one arm and pulse oximeter to the other arm. Both the surgeon and the patients were comfortable during the entire process. We operated the right eye after a span of 1 month with the same arrangements. A beautiful smile lit our patient's face as she was wheeled out happily at her 3 months follow-up, with the uncorrected visual acuity of 6/9 parts in both eyes that improved to 6/6 with correction. Difficult roads often leads to beautiful destination. Thank you.
Amazing, Jimit.
Thank you.
The block was local.
Sir?
Local anesthesia was.
Sir, we gave a subtenon block. Yes, a local anesthesia.
Okay, okay. Good. I think only the hand resting would have been the most difficult part.
Yes, sir. It will be like
You
you
have
have
to keep
to
it in the air.
do the surgery with a stretched hand, sir.
But does all the microscope tilt the 90 degrees completely?
Sir, all the lumera, I think it will tilt 90 degrees, I think, sir.
Okay, okay. Good, very nice.
Thank you, sir.
Any comments from the panel regarding
both the patient and the surgeon is comfortable is a catchy word there, actually. Very nice, Dr. JP.
Thank you, sir.
The surgeon may have a mild difficulty. The surgeon may have a mild difficulty with his spine if he's bending down so much and trying to operate on.
Not bending down, sir. The little difficulty we have is outstretched hands, like, so that when you are, you have to try to finish in 5-10 minutes of the surgery.
It's a very good.
Bit at the start of the OT, first patient.
Yes, might be, but we have to, usually I do it at the end of the day, sir. Might be afternoon time, because we have to arrange the OT in such a way that the regular positioning will be the tables and the microscope has to be changed to this position, so that I'll do it in the last day,
right.
last case in the OT.
Satyan
You
sir,
need to have a fit surgeon with a good core strength, right? Because an outstretched hand, very, very difficult. So for even 5 minutes, very difficult. And that too, if you're doing a surgery with a stretched hand without any support. So that's quite difficult.
I'm not sure whether this innovation is slowly going to change from sleeping position. All cataracts are going to be done in sitting position and discharged sooner.
Yeah. No, once you get robo, it will be possible, Nisha. And patient might demand, and we should be offering it as a premium surgery.
Yes, sir, because I think J.K. Reddy sir is already making a prototype of the LASIK, which is actually being done in sitting position.
Sitting position, yeah.
Yeah, slit lamp integrated one.
Yes.
They were almost done more than 20 cases, I believe.
Yes, sir. With good results.
Jabed, it was nice, very nice.
Thank you so much, sir.
So all wonderful presentations, which can, if you should scale it up and try to bring it to the mainstream. It should not remain as innovation. It should come as a practitioner's armamentarium. And many of them are social innovations also that will reduce the cost as well as affordability. And some of the presentation was mind-boggling and very thought-provoking innovation, because in conferences, I think at least the seniors tend to miss these sessions. So when you bring it as a separate session, we're able to see the magnitude of the new thought process happening in not only in our hospitals, and also I think many presentation from Arvind Eye Hospital. So I should congratulate the mentor and guides who actually help these innovators to put their ideas into the making of these innovations, as well as bringing it to its logical conclusion. So kudos to the entire team and the presenters, and also panelists who nudge them to think again and also think in the right angle. So thank you, Suresh, Devdutt, Manoj, and of course, Nivian, Satyan, Dr. Veni Priya, everyone, Manoj, and also to all the presenters. So thanks a lot. Well done. And big thanks to Nishant and Prasanna for cobbling up this group of innovators, youngsters. So it was a real 2 hours of science, innovation, new ideas, and of course some technology, and everything integrated into a high-tech ophthalmology. So thanks a lot, all of you. So over to you, Prasanna, for the formal vote of thanks.
Yes, sir. Thank you, Nirmal sir, for this wonderful initiative of the Young Ophthalmologists Task Force of TNOA. And we had our first debut webinar, which is one of many to come. I promise, sir, one per month. So we'll have one of many to come. So thank you, President, sir, for this wonderful initiative in recognizing the young ophthalmologists of TNOA. And next, I would like to thank our immediate past President, Ramakrishnan, sir, President-elect, as well as our Vice President, who all joined in this meeting. And a big shout out to our beloved Secretary, Sriram, sir, who guided me and Nishan sir in every step, starting from the designing as well as in getting the things done in the right way. I think I have disturbed him the most, along with Nishan sir and Nirmal sir. It's a total team effort. And thank you, Sriram sir, for that. And we also thank all the office bearers, our treasurer, joint secretary, joint treasurer, ARC editor, as well as all our fellow managing committee members for this wonderful support from on behalf of TNOA. And also it's not possible without this wonderful team, the YO task force that has been assembled, starting from the dynamic chairperson of us, Dr. Nishant sir, and the young team. I don't want to name each one of them, but I just want to acknowledge them once again by showing who they are, as well as our advisors. At every step, when we had the first meeting, each one of them guided with their inputs, be it Nivian sir, Manoj sir, Vinod sir, Aarti, Digvijay sir, or Sonal madam. They all guided us that we'll have one surgical topic, we'll have one medical, one social. I think that really mattered. It's a total team effort from TNOA as well as this young task force that we are seeing. And we also would like to acknowledge the designer who helped us in designing. His name is Mr. Bala. And Numerotech, I think they helped us in getting this flyers out. We had a lot of promotions, and I think I would like to take this opportunity to say that on social media, we have had the maximum hits in 1 hour. I think we had more than 25 likes, and I think we have crossed 100 and 150 views, which I promise, sir, I don't know the exact count, sir, but I think it'll be one of the high impact webinars in terms of views and likes. So thank you, Nirmal sir, and the entire TNOA office. If I have forgotten somebody, it's just by memory and not by willingfulness. And thank you each and everyone, including the panel, each and every member, the audiences who are there. And we'll keep continuing to give our best with the initiative under the guidance of our president and the respective office bearers. Thank you. Thank you, sir.
Thank you. Dr. Sharmila is eagerly waiting you to beat your record next week.
Hopefully, I made it tough for her, is what I believe, sir. Let's see, sir.
So there is Sriram has also joined for the closing.
I was online, sir, for the last talks.
So thank you, Sriram, for guiding this youngsters.
All his works, all.
No, sir, I have disturbed him a lot. Many phone calls.
He is fresh from a vacation. You can't disturb him further.
No, the one thing I really, I don't know, sir. Just know Tricon is over, and sir would have thought of taking a break, but
Already, yes.
we had other ideas. We never allowed him to take a break, sir.
I think we'll go
Prasanna,
offline.
yeah, it was your influence, sir's hairstyle, or sir's influence of your hairstyle?
It's my influence is hairstyle.
Hopefully, it's not due to Tricon 23 budget decision.
I was about to say that, sir.
I hope we are offline. Thank you, Manjula and Sai. Thanks for hosting the program.